If I may introduce our second speaker, who is actually our gives our keynote speech tonight, and that's Professor Paul Leeson, a colleague and friend of mine, who is a professor of cardiovascular medicine at the University of Oxford. He's a fellow of Wolfson College and head of the Oxford Cardiovascular Clinical Research Facility. And he is going to educate us about the novelties of technology that we can bring into the stress echo arena to help accuracy and prognosis. His lecture's title is What Can We Expect from the Use of Artificial Intelligence in Stress Echocardiography? Paul.
Lovely. Thanks very much, Attila, for the kind introduction, and thank you very much, Howard, for a great exposition on the use of contrast and some really nice case examples of stress echo use. Great. So yeah, thanks very much to Bracco as well for inviting me to come and give this talk about the use of AI and stress echo. It's a topic which we've been working with for some time, and I can give credit to Harold for some early ideas in this space, and also for Attila for discussions along the route. I think one of the things which we have all said so far is really, just going to put up those which are my declaration of interest in this field, reflecting my work in the space, which some of this will be mentioned during the talk. I think I'm going to start off with this, which Attila has also brought forward, which really highlights the fundamental role of stress echo in coronary disease management. And there has been lots of conversations over the years about where stress echo sits and will it all be replaced by other imaging techniques. But 2024, we are here today. Stress echo remains really the workhorse of coronary disease identification in moderate and high risk patients, as it has done for a long period of time. And what we know is the value of functional imaging in this group is that you can use it really practically to change the patient pathway. You can, if you identify disease on stress echo, there's evidence of severe ischemia, then you are making real decisions at that situation to forward on for invasive investigations and professional treatment, and also you're guiding management in terms of decisions about lifestyle risk factor modification. So it's very important that we get stress echo right, and we appear to. If you look at the recommendations as being highlighted, stress echo remains as this class 1 recommendation for use within coronary disease management. And what I'm going to do differently from what's gone before in terms of the presentation is to just highlight the references that are being used to justify this level of evidence. And if you dig into the details and go to the reference list of these ESC recommendations, one of the key papers that it recommends as the basis for this evidence is this study, which is highlighted at the start, the Everest study. So this is forming really the evidence base for why these ESC guidelines are pushing forward stress echo among other key studies. And I want to tell you a little bit about the background to this study because it's relevant to our journey within the use of artificial intelligence. This is a study which is involving around 30 different NHS trusts within the UK. These trusts are spread across England, Wales. We also actually have a centre in Scotland and across into Northern Ireland. And these are really centres which have been a workhorse for stress echo within the UK. The study started back in 2015, and over that period of time, as we've been brought on board new phases of study with addition of new sites, we have seen recruitment increase steadily over this period of time, which has really reinforced even further from 2020 onwards when it became an official network of the British Society of Echo in this partnership where we've been able to develop a really large-scale clinical cohort study of stress echo practice. We completed recruitment actually in 2023, and at this point we had recruited 18,000 patients into the study. The study has been enhanced by the ability of within the UK to be able to link patient outcomes across NHS digital infrastructures, which allow us to look at long-term outcomes in this cohort. And it's been very interesting to dig into this data set, which has really given us a capture of stress echo practice in the UK in real-world practice across a 10-year time frame. What's really good about this data set is this isn't one single academic centre feeding all their stress echo data into this study. These are figures showing the range of index of multiple deprivation, which is a socioeconomic marker of the type of hospitals which are involved, which spread across the full range of different socio-demographic settings. These are hospital bed sizes, which range also across the typical range of hospital bed sizes, cardiology attendance, and also the number of stress echoes performed. So there are some centres which are really performing just a few hundred stress echo a year, and there are some which are performing many thousands. So it was really a great snapshot of stress echo practice, which is representative of many health systems in other locations around the world. And this is what we report in terms of 6-month follow-up data. As has been highlighted, this just represents real-world practice. So in the UK, we are using about 70% of stress echoes that are being done with contrast. And there's no particular selection of this. This is just what's happening in the UK. And the accuracy over these short time frames of 6-12 months are very good in terms of identifying those with coronary disease and also those without coronary disease. What's been really nice about this kind of data and this access to this data is also it allows you to look at real time in terms of what's going on. Because this data is flowing in over different periods of time, you can look at how stress echo practice is changing. And this was one of those pieces of paper which was really quite insightful in time a few years ago, the COVID-19 pandemic, really because no one really quite knew what was going to happen. Was stress echo going to be wiped out with the COVID-19 pandemic? But in real time, we're able to look at what happens. And this is one of the really interesting features. So pre-COVID, we had a lot of sites which are performing dobutamine stress echo, and also about a portion of sites were doing exercise. What we saw with the first wave of the pandemic was that exercise suddenly disappeared and dobutamine was used. And then with the second wave of COVID in the UK, we saw exercise come back into play. We also saw the number of patients per list actually increased over this period of time. So it was one of those things which continued. And although the number of lists dropped, it increased. So this gives you real-time information about practice and stress echo in the UK. So you might ask, if stress echo is so good, we're using it, has very high accuracy, it's being used across the UK, it remains the most common used imaging test to study patients with coronary disease, and it remains front and foremost of current ESC 2024 guidelines for coronary disease. Why are we trying to improve it? What is it that AI could possibly add to stress echo being performed with contrast in the UK? I'm just going to show one example, and this is a real case example, which was kindly provided by one of the consultants' colleagues within the Thames Valley area to illustrate why there might be still room for improvement. And this was a 74-year-old woman who came to a rapid access chest pain clinic in Oxford in November, a year or two ago. She presented with chest pain symptoms, and as we know from other studies, it can be quite difficult sometimes to interpret or chest pain symptoms in different situations.
Without further ado,
and make a diagnosis.
I'm going to now
and so she was referred for a stress
introduce
echo.
our first speaker.
This was performed in January. Of note, during the study, contrast was used. She actually felt quite unwell during the study. They weren't able to use atropine because she had glaucoma and she just had dobutamine. She became slightly vagal, but she got up to a peak heart rate. But the operator found it quite difficult to decide whether or not there was regional wall motion abnormalities there or not. I was distracted by the patient who was feeling unwell during the procedure. But a set of stress echo images were acquired. And because of this uncertainty, they were actually referred for a second functional imaging test. And so a myocardial fusion scan was performed in February. Of note, there was some attenuation noted in this woman, but it was felt overall that there was probably normal perfusion, and this report was sent back to the operator. As a result, when the woman came to the rapid access chest pain in February, she was told it's probably non-cardiac pain, and she was discharged. But the pain didn't go away. And a few months later, she came back to the chest pain for further review, still complaining of chest pain. If anything, it was a little bit worse. And because she was starting to develop symptoms which were quite classic for angina, she was actually sent for invasive coronary angiography. And this is what came up on the angiogram. And many of you obviously will be familiar with angiography as well as stress echo imaging. And I think we will all agree there is clear evidence there of coronary disease affecting several territories, particularly easy to pick up is the one on the right coronary. But there's also disease as well. If you look in the LAD, just in the mid-LAD there, there's a disease and circumexternal disease there as well. She was started on treatments and medications, her symptoms improved, and a diagnosis was reached. I thought it'd be interesting to have a look at the stress echoes. These are the stress echoes she had back in that January of that year. The top row represents the images. So we've got a 4-chamber view on the left and a 2-chamber view on the right. Rest, low dose, peak, and recovery. So really nicely performed stress echo across the range of heart rates with really nice delineation using contrast. And I think I won't test in terms of who thinks they can see abnormality there or not. I would highlight that actually there's a little bit of foreshortening, which Howard has pointed is not a good thing on the peak 2-chamber, and also on this low dose. So perhaps probe position could have been improved, but the 4 chambers, the peak and the apex are not moving. And I think, in fairness, in the heat of the situation, I probably, I think the operator could be forgiven for doing not necessarily picking up what's going on in a fast and busy list. Because it is being done, and I think, however, what perhaps if with a bit of time you might see, and maybe we'll see in the question Q&A session with people agree, is the apex is perhaps not contracting normally compared to what it was at rest at peak, and it does recover later on. And you can ascend, although this is foreshortened again, maybe some abnormalities just in that apical anterior wall, which might be hinting at problems. So this is really where AI comes in, because what we are doing and what's been highlighted, we are assessing this by eye. We are looking with our eye, trying to understand and pick out these wall motion abnormalities. So if you've been in stress echo all week and you get to the Friday list, you have a list of 5 patients and you're getting tired, are you really performing as effectively as you were on day 1 of that week where you're seeing the stress echoes? But having said that, because it's an expert qualitative image interpretation, does raise the possibility of whether AI might be able to capture some of that expertise, provide a more consistent and regular interpretation. And really, this is the drive behind why it might be interesting to use AI within a stress echo perspective. I would like to step back in time for a moment and sort of provide a slightly more sober thought on this, because when we talk about AI, we obviously talk about new technologies, exciting ways forward, what might the future look like with AI as a concept. Isn't it amazing that we can do AI now? And I'm going to take you back to this conference abstract, Seeds of Artificial Intelligence, which raised to a conference actually from the early 1980s. And if you dig into this conference and you look at what's being proposed in this meeting, which is being held over in Stanford in the early 80s, I always like seeing this project, which was started in November 1978. And what it was proposing was that the ultrasonic imaging project would build on past experience and use of computers and ultrasonic techniques to model body organs in 3 dimensions. And they would be used to look at non-anatomic structures. Data would be obtained to get clinical diagnosis. And although the initial system might be designed to send volumes of things like fetuses, indicator weight, later it will be extended to measure the volume of the liver, the kidney, and even the left ventricle of the heart. So we've been trying to tackle this with AI for 40 years at least. And I think the real difference, as I acknowledge, is if you then still look at that conference proceedings, this is what they were working with. And on the left is actually quite a sophisticated network of sites who are feeding data into their concept across different institutions, so much similar to our own networks, perhaps an early version of an Everest network that we have. But what they had is the computer that was processing this is illustrated on the right. And I'm really struck by the use of stained glass window in the top right corner as a highlight of the type of technology which is being used here. And over the 40 years, 2 things which have changed is our access to data and our computing power to deliver AI at scale within medical practice. So what if AI had been available to assess this stress echo back in January? Would that have saved 7 months of time in terms of really getting to a diagnosis of coronary disease for this patient? Well, interestingly, AI was available for this patient because they were taking part in a study, in a trial, and an AI report was provided for this patient at that time. And what the AI report said was this. This was a computer which had basically been fed the images, just the images, no other clinical information, and interpret the images to provide this input to the operator. And what it said was stress echocardiogram are suggestive of a higher possibility of significant coronary artery disease. So how could the AI have got that right with the operator not being confident in their diagnosis? Well, this comes back to the Everest study, and some of the early ideas for why we wanted to set up the Everest study was to start to collect real-world generalizable data which told us something about stress echo practice in the UK, and be able to work with imaging data sets to extract information about that would allow us to predict likely outcomes in this patients. And the idea of the AI development that we did was not to be able to mimic consultant practice and not to be able to understand whether you could pick up readable wall motion abnormalities or areas of change in function, but actually to say, if you take the image itself, can you predict the likely outcome for this patient? So can you predict whether this patient is likely to have coronary disease when they go for angiography? And that's what we were trying to model, not just look at wall motion changes. What this required was a series of builds of different AI models. So there wasn't one simple solution to produce this. And I think we learned along the process. So the process for this did start back in 2015, 2016. And we learned through the process to actually be able to do this in a robust way. It doesn't just require one model, it requires a series of models and challenges to overcome. Some of these now are standard practice, but none of this was standard practice when we started. One of the first things to tackle is make sure that the computer you're developing can actually recognize the view that it's seeing. So can it identify whether it's an 8.4 chamber or an 8.2 chamber? There was no way of doing this when we started with this work. It's now fairly standard and straightforward for any computer algorithm to be able to pick out what view it is. So that was the first step. For this particular approach, what we decided to do was use a fairly traditional auto contouring approach, so you can identify where the heart is sitting once you know where it is. Well, again, interestingly, when the early concept, we didn't really have a way of doing this, but what came along during the pipeline are things like UNETs, which have been very effective at segmenting ventricles, and are now underpin a lot of the routine available techniques for quantification within legacy carts and other machines which are available. So contouring became key. From this, as soon as you know the contour and you can identify different areas of the cardiac cycle, again, you can build a model to learn where different parts of the cardiac cycle are. You can start to extract interesting sets of metrics and a whole range of novel metrics, which allow you not just only to assess standard metrics like ejection fraction and global longitudinal strain, but also a whole range of novel kinetic and geometric metrics to build. And then you can train your model. The final step, train your model using these metrics to understand disease prediction and develop ways of presenting things back to the individuals. This is, we published this data back in 2022, which looks at the red represents the training data set, which was used on several, on sets of hundreds of echo data sets we had within the UK Everest study, showing a good performance, an acceptable level of performance for accuracy, for identifying specifically likelihood that they had significant coronary artery disease if they were to go for angiography, and significant coronary artery disease are defined as a stenosis of greater than 70% in a major coronary artery. And the green dotted line is a test data set which was taken from OHSU in the US of similar stress echoes to show that the performance held up, even though this was looking at a completely new external independent testing data set from a different country. The nature of this particular model related to stress echo is because it's built from metrics that are extracted from the images, you can actually look at some of the metrics which are being used to drive this differentiation. And then I've just picked out 3 examples of these are published in the paper, which looks at this, looking at the sensitivity and specificity of these individual metrics for identifying change. And these are not metrics we typically look at in stress echo that we know of, but perhaps we are looking at these when we visually assess the stress echo images. There's one looking at actually rectangularity of how rectangular the ventricle is in the 4-chamber view. There's one looking at tortuosity, and which is looking at how it's moving within the skeins. And this is looking at just velocity in a particular segment of the ventricle, seeing how that changes as well. And you can see in these 2 dots, those who have coronary disease, so a positive outcome on the coronary angiograms, separate quite nicely from those who don't have any coronary disease on their angiograms for all these parameters. And any individual parameter gives some degree of precision in terms of how you differentiate And clearly within the AI model, all these are putting together to improve performance. This is a case example, again, taken from the paper, looking at what operators across the data set of test data sets had felt where the regional wall motion abnormality was on average in a particular case. This was on the left, you have at peak stress where people were identifying where they thought the regional wall motion abnormalities were in a whole range of data sets on average. And this is what the model was picking up. So similar, it matches what operators were seeing, although it wasn't being trained on the wall motion abnormalities, was being trained on coronary disease outcomes. There were similarities in what was being seen. So I'm going to take us back to the patient we were talking about, the coronary disease patient. And this is the outcome for that individual who had their stress echo, which I was talking about, the 74-year-old woman. Along the bottom are all those different parameters which are being seen. This is what the model sees as normality, the green range. This is what the model sees as likely coronary disease. And yeah, as you can see, it's identified several parameters which are falling within the coronary disease range, as well as several parameters and areas which are falling in the non-coronary disease range. The interesting thing is, if you take those parameters and map them onto those stress echo images which are required, this is not, I put here in the regional wall motion. Already what these arrows are showing is where in the heart the model was thinking there were problems. And intriguingly, what it does is it matches to those subtle changes on the stress echo images which are being picked up, suggestive of coronary disease on the baseline. I'm going to highlight another interesting point, this wasn't a retrospective analysis of data, this was a prospective study. And what we were doing within this trial was providing the report back to the operator to say, this is what the AI thinks, how is this going to influence your decision making? However, the final decision was left up to the operator. Clearly, what's really striking about this is in this situation, the operator chose not to take account of the AI, but actually opt for another process. It's entirely possible that the arrival of this AI in their inbox might have prompted them to think that actually perhaps we need to do another functional imaging test. But the AI in itself was not enough to change the decision-making of the operator who felt uncertain. What's intriguing is what they did was they went on to choose myocardial effusion imaging as an alternative stress functional imaging test, which gave back with a negative, what turned out to be a false negative result. But they were more reassured by that than necessarily what the AI was telling them. This really is intriguing from an AI perspective, and one of the challenges it remains, which is the operator-AI interaction and decision-making. This was slightly unexpected because actually one of the things we did was a separate randomized reader study where we took stress echoes and we provided, with a set of about 150 studies of stress echoes, provided them to readers to look at in a randomized way. Half of those readers got an AI report, half didn't. There was then a washout period where they were given a chance to forget those images so they hadn't seen, and then everything was swapped over. So every reader saw the images without the AI and with the AI in a randomized order. And then we looked at the results of that reader study. What we found in that randomized reader study was that the solid line represents the reads of those stress echoes with the advantage of AI, and the dotted line without the advantage of AI. And you can see across the range, whenever they're getting the AI, they were getting more precision in terms of their diagnosis. Not surprisingly, with that increased precision, and we had a range of expertise within this group, what you did is reduced intervariability operator. So what happened was those who were less experienced got closer to the expertise of the expert operators in terms of their precision around their diagnosis. So you reduced variability. But the other thing we did is we asked them how confident were they in their interpretation of that stress echo. And what was really striking was that they all were, on average, confidence in reporting of the stress echo improved. Of course, what was intriguing is this was a reader study. This was just looking at images in isolation. You had none of what goes on in a stress echo lab, none of those patient feeling unwell, which is also feeding into your decision-making process. But in isolation, what the AI do was improving the accuracy and the confidence in your diagnosis. But I think what we wanted to do was take this a step further. And this has never been done with an AI application in stress echo within cardiovascular disease before, which is not just do these reader studies, not just look at accuracies, but say, if you put an AI device into real world practice, how does this change patient outcome? How does it influence decision-making for the patient? And this is really critical, I think, in terms of our understanding of how AI needs to be implemented into practice. If we're really going to innovate and bring AI into clinical care, not only do we need to do that training and validation of AI, and there are hundreds of examples of training and validation of AI in the literature, we need to take this through into understanding stakeholder acceptability. We need to get the FDA, and we need to do some real world testing of AI. So what we ran was a study called the Proteus trial. This was a multi-center randomized prospective controlled trial in adults undergoing stress echo. It involved 20 hospitals across the UK, and we recruited just shy of 2,500 patients. We excluded patients who'd had previous coronary bypass surgery or cardiac surgery because the model wasn't trained on those particular patients. And we excluded patients with moderate or greater valvular heart disease as another factor. And these patients were randomized to either receive randomly either just be managed as routine, or in random form, the individual operator would also receive an AI report. This required IT implementation within these 20 hospitals across the UK, and the ability to pull images and drop back images the AI reports back into the systems. But it was possible to do this with the mean turnaround time of about 10 to 15 minutes to get the AI report back to the operators. The primary endpoint that was chosen was interesting. It was an appropriate referral for patients for invasive coronary angiography. So what we were testing was, if you had the AI, could you change the decision making? I.e., could you push patients to getting better select patients to have invasive coronary angiogram? So the outcome did rely on patients being referred for invasive coronary angiography. The decision was to take a non-inferiority approach to this as a safety approach, to show that actually selection of AI did not make things worse for patients. There were secondary analyses predefined, which looked not just at non-inferiority in some pre-specified subgroups, which were known to be challenging to analyze a stress echo, and also looking at different characteristics of centers. To cut a long story short, this was presented at the ESC in September, and has been published in the New England Journal of Medicine AI manuscript. So this is available to look at and is out there in the literature. One of the striking things was there was a difference, an improvement in patients in terms of those decisions being made for who gets referred to coronary angiography. But what we did notice during the process of the trial was that the number of patients being referred for coronary angiography, likely because of changes in practice of selection of patients for angiography, that those with moderate ischemia now typically are managed medically rather than being sent for ischemia. The actual absolute number of people being referred for coronary angiography significantly reduced than what we were seeing 3 or 4 years ago. And as a result, the study was underpowered to be able to show that there's a difference between the two groups. Nevertheless, the size of effect we were seeing was just as we predicted from the READER study. If you look at those predefined subgroups, I think one of the things that does strike out is the one predefined subgroup, this is when you take account for adjustment, was interestingly that those sites who have low volumes of stress echo, the implementation of an AI appeared to be significantly improving didn't maintain accuracy over other sites were performing more stress echo. So I think this does highlight a few things. And one of those things goes back to our initial point, which is actually we are starting from a very high baseline. So stress echo as performed in the UK has performed very well. Particularly with the high use of contrast, high use of precision, high good level of training, high volume centers, we know the outcomes of stress echo are very good. I'm going to share with you this data, which is the long-term outcome from the Everest study, which now extends out to 5 years post stress echo, just published, actually literally just this week in European Heart Journal Cardiovascular Imaging, showing outcome, how use of stress echo can predict outcome in patients. And I'm just going to pull in particularly that figure from the lower left. And this looks at what your likelihood of having a myocardial infarction might be if you've had a stress echo, stratified according to your ability to identify, or the operator's ability, without use of AI, to be able to identify whether there is no sign of ischemia, 1 or 2 segments, 2 or 3 segments, or 3 or more segments of ischemia. And you can see the ability to stratify risk of events is even quite high based off your stress echo, very nicely in a graded manner based on the number of ischemic segments you're seeing. This is looking at the warranty period of a negative stress echo. So if you have a negative stress echo and you follow up patients after a negative stress echo, you can see that if there's no previous coronary artery disease and have a stress echo, their likelihood that they have a stress echo is really no different and slightly less than what you'd expect within the population that is going forward for stress echo anyway, even in terms of the event. So out to 5 years, their rate of stress echo is no different from the background rate for typically the same type of patient. If you do have previous coronary artery disease, it pretty much tracks it, probably slightly higher. So, but certainly out to 4 years, if you have a negative stress echo, again, you've matched the expected rates. So the precision of stress echo is good. Interestingly, the AI does give certainly in its training, its ability to improve in some of these studies, but the referrals for coronary angiography are quite different. But it's exciting. I think what it demonstrates is an automated machine can read a stress echo, but what's really important is you look at how this maps into real-world practice when you start using AI, and that's the real test of where you're going to see the value. What you take away from the current state is that there are areas of improvement that can be brought into play here, and the indications and the way these things are developed can be really enhanced, and really looking forward to future randomized controlled trials in the AI cardiology space.
Thanks very much, Paul. Excellent and very intriguing insights into the current practice. I would have said future, but these are things that we are already living with and we are doing already. And the way how the data are processed and AI is looked at, will give us much faster access to these AI driven softwares that we can, or devices, if you like, that we can utilize for the benefit of a more accurate diagnostics and prediction of outcome in patients undergoing stress echo. So it's excellent talk. Thanks very much. I'm sure that there will be plenty of questions coming at the end of this session.